morning, everyone. Today, I am going to discuss discuss the topic of concomitant versus staged management of axial reflux and tributary disease. So, the emergence of endovenous ablations has really transformed the surgical management of superficial venous insufficiency. We all know that the minimally invasive approaches that we offer at CVR are very comparable to the long-term outcomes to that of the open ligation stripping procedures that were previously popular. Furthermore, the lower rates of peri-procedural pain allow for earlier discharge and sooner return to normal function, which contributes to an overall improvement in quality of life. This approach has really established safety and efficacy, which has allowed for more immediate and comprehensive treatment of superficial incompetence. And so the shift in venous paradigms has led to the advent of ambulatory care and the office-based treatments that we offer at CVR. This process has been further augmented by the evolution of tumescent anesthesia, which now allows for adjunctive therapies such as phlebectomies to be performed as staged procedures or even concomitant procedures in this ambulatory setting. And a lot of time, the timing of these procedures is based on the discretion of the surgeon, in a conversation that needs to be had between the surgeon and the patient. However, the timing continues to raise debate among physicians because has been quite a bit of conflicting evidence. It's been proposed that a staged approach to varicose tributaries, especially following endovenous ablation, allows for varicosity regression, which in turn may result in a reduction in the need for secondary intervention. However, we've seen this, for example, we've seen this somewhat play out with Aetna's recent policy changes. And by contrast, some data suggests that concomitant intervention may be associated with significantly lower rates of secondary intervention and an improvement in short-term quality of life. And so that brings us to the objective for this presentation, which is to compare the outcomes of both concomitant and staged tributary interventions as an adjunct to superficial ablation in the management of symptomatic chronic venous insufficiency. The first article that I'd like to go over here is, a study that was published um, in the Annals of Vascular Surgery. Uh, the study included 132 patients, 76 male, 56 female, um, who were treated with endovenous laser treatment and ambulatory phlebectomy. Another 133 patients were treated with only EVLT. About 85% of the patients had bruising. More than 20% of the patients had pain as their major postoperative complications. However, there were no significant differences in the complications noted between the EVLT only group and the combination group. And during the follow-up period, uh, it was observed that residual tributaries were noted in 12 patients in the combination group and 11 in the EVLT only group. So EVLT as the sole therapy for the management of combined saphenous and tributary varicose veins was found to be safe and effective. However, the group also suggested that longer follow-up is needed for the confirmation of these findings. Another paper that was published a year later uh, in the British Journal of Surgery was this paper by Caridas and team. Uh, Basically, it was a similar study. It was performed in the United Kingdom and published in 2009, as I suggested. Researchers randomized 50 patients into two groups. The first group had truncal GSV EVLT with concomitant phlebectomy. The control group had isolated truncal GSV EVLT with a staged phlebectomy for varicosities after 6 weeks, and that's only if it was required, of course. Investigators found that the combination group took longer The procedure itself was longer, but significantly decreased the requirement for subsequent interventions, which seems a little obvious. Uh, there was no impairment in immediate post-procedural pain, and VCSS at 3 months was actually lower for the combination group than EVLT alone, with lower ABVQ scores at 6 weeks and 3 months. At 1 year, however, there were no differences in VCSS or ABVQ scores. And so the paper concluded that concomitant fleb with EVLT prolonged the procedure but reduced the need for secondary procedures while significantly improving the quality of life and severity of venous disease. Concomitant fleb alongside EVLT was well tolerated with no significant increase with no significant increase in post-op pain. And so there was a trend towards faster recovery in those who had the um, EVLT alone, but this did not reach any statistical significance owing to the small sample size of the 50 patients. The data also suggested that if patients did not undergo phlebectomy at the time of EVLT, it took up to a year to see the quality of life benefit as those who had the concomitant procedure. So I guess the takeaway is that the secondary interventions, if they were performed after the fact, it took quite a bit longer to reach you know that same outcome, which was around a year. And you can see that in the graph here. Another relevant article that I found important to include in this presentation was a study that was published in the Journal of Vascular Surgery. This article reviewed the outcomes of 735 patients who underwent 1,000 consecutive GSV and SSV endovenous closures with 500 concomitant or staged tributary vein phlebectomy procedures between 2004 and 2012. 507 limbs had incompetent symptomatic tribs. Phlebectomy was performed concomitantly with RF in about 30, not about, in 30, 355 limbs. 126 limbs required phlebectomy at a, in a staged manner. And that's only if if there were persistent symptoms in those tribs. 26 limbs with reflux and varicose veins following RF did not require any phlebectomy at all because their symptoms improved with RF alone. And so what they found was 95% of limbs, about 487 patients who had superficial refluxing tribs who underwent the saphenous ablations did eventually require stab phlebectomy, either concomitantly or staged. So overall, the findings suggest that concomitant phleb is a safe and effective treatment for patients with incompetent symptomatic tributary veins. And so, as mentioned before, 83% required the phleb either during or at a later time due to persistent symptoms. Clinical response to combination therapy in the treatment of these varicose veins, uh, you know, most, let's put it this way. Clinical response was positive. There was, uh, excuse me here. So I'm going to skip through this. Basically, the data suggests that patients do benefit from the direct treatment of varicosities, in addition to axial vein ablation. And what we know is with combination therapy, it may be a more effective treatment strategy than saphenous ablation alone. Sorry about that. So basically, this paper is saying the same as the previous two studies, which suggests that concomitant procedures uh, may fare a little bit better in terms of post-op perioperative pain and reaching those outcomes sooner. A more recent study, it was published in the Journal of Vascular Surgery. It was the clinical response to combination therapy in the treatment of varicose veins. Um, so this was based on data that was gathered from the American Venous Registry, and you basically concomitant therapy included either phleb or foam sclerotherapy. So whereas the previous procedure the previous studies really took into consideration concomitant phleb only. This study, because the data was sufficient, included foam sclerotherapy as an adjunct procedure. So this one is interesting. And so what we found, well, 526 patients were included in this study. And what we found was combination therapy resulted in a lesser VCSS score at the 1 month follow-up. So compared with standalone therapy, combination therapy was associated with about a half a point reduction in VCSS, statistically speaking. And then after treatment with combination therapy, there were lower scores on the pain and the varicose vein components of the VCSS score. And similar to all the previous papers, the data does suggest that patients do benefit from the treatment of varicosities, in addition to axial vein ablation, and that too with combination therapy as opposed to just axial ablation alone. Lastly, there's a paper here, a review and a meta-analysis um, covering concomitant versus stage treatment of varicose tributaries was published in, I believe, 2020 here. So this paper reviewed 15 studies. Over 6,900 limbs were analyzed. The outcomes assessed included reintervention, complications, thrombotic events, quality of life, and disease severity. Reintervention rates were significantly lower in the combined therapy group, 6.3% versus 36.1% when compared to the staged intervention group. Reported complications and rates of deep venous thrombosis were similar in both groups. The overall VCSS score was lower in the combined therapy group, and quality of life, as assessed with AVVQ, favored combined therapy when measured at less than 3 months and also between 3 months and 12 months. And so, uh, what this meta-analysis showed us, and this is the same thing that we kind of hear repeatedly from these other papers as well, is that both concomitant and staged tributary interventions are safe and effective. The data suggests that concomitant intervention offers significantly lower rates of reintervention with equivocal rates of reported complications and thrombotic events. The axial ablation alone was sufficient therapy for 63.9% of those that were assessed. So, one could argue that the staged intervention may be associated with higher reintervention rates. So there may be that bias. But initial tributary intervention is associated with greater improvements in early disease severity and AVVQ scores, with the effect maintained with regard to the quality of life up to a year. So similar to what one of our papers concluded before, and it's that when we do perform these concomitant procedures, we achieve those, exemplary AVVQ scores sooner, and the quality of life, uh, is superior up to that 1 year mark, where the standalone procedures or the staged procedures do tend to catch up. And so uh, that's all I have for today's presentation. If anybody has any questions, this would be a great time to have that discussion.
Hey, Kas.
Yeah.
This is Ken Nguyen. Hey, just a great talk. Thank you very much for doing this. One of the things that I always find challenging is that I clearly think that doing the concomitant phlebectomies for big ropey veins, just extensive varicosities, those are the ones that benefit the most from doing it concomitantly, because if you don't do them relatively soon after an ablation, what happens is they tend to clot, and that's where you get the severe thrombophlebitis. And if you get one of those one time, you'll always remember like, oh crap, why did I do that? Why didn't I do this? And essentially that patient is going to be miserable forever, and or just for a long, long time. And those patients tend to benefit the most from doing concomitant phlebectomies. But the challenge is that when they're so extensive, you want to do them in a staged fashion because, obviously the patient's already been on the table for so long. They've already had the ablation. They've already been poked already. And then obviously doing a phlebectomy that's extensive.
Yeah, Ken, we lost you.
Takes a lot of our time as well. So those are the ones that benefit the most. But ultimately, you kind of have for the patient. Okay, are the ones that have just like a couple of bulging veins, and then you do those concomitantly. But theoretically, you don't even need to do them right away. Those are the ones that can actually wait because they don't tend to clot as much. So that's the challenges that I kind of go through in my day when I'm thinking about how do I manage a patient, and which one do I do concomitantly and which one do I do staged. Okay, and then just a final comment about choosing the number of stabs for phlebectomies. But one of the things that, just as an aside, one of the things that I always, when I talk to doctors, one thing that I always hear is that you got to get to a certain number of stabs to get paid. Okay. And I want to make sure that I clarify this for everybody. All right. There are codes where you have 1 to 9 phlebectomies. There are codes where you have 10 to 20, then there's codes that are more than 20. Those are established codes, but there is a miscellaneous code that actually pays you for the 1 to 9. Okay, so I never want to have anybody feel that, oh, I got to do at least 12 stabs or 11 stabs in order to get paid. First of all, we always want to do what is appropriate, and we want to document what we actually do. Okay, so there is absolutely a code. It's called the miscellaneous code, and it lets you get paid for doing 3 stabs, 4 stabs. Okay, so we should never say, "Oh, I need to get to 10 or 12 in order to get this paid by us." It's just that should never be the decision making process of how we manage a patient. Okay, it does take a little bit more documentation. It does take a little bit more billing. Submission of bills and codes and everything else. But that's all done by the billing team, and it's all done from the backside. Okay, but just to be clear, I know many of you guys already know that, but I also hear it so many times, and I just wanted to make sure that was clear for everybody.
Yeah, Ken, but Aetna doesn't accept the miscellaneous code for 1 to 9. If you put a miscellaneous code for 1 to 9, it'll come back as a denial.
Okay. Yeah. Ultimately, if there are going to be some codes that may not, right. But I will tell you though that when I talked to Betty about this, she says that it comes back as a denial, but then we submit, and you're right. We may not get paid for some of them, but ultimately, we never want to do something that is unnecessary. Okay. Ultimately, guys, we make a great living doing what we do. And ultimately, if it winds up being that, yes, we did 3 stabs on a patient and it took us a little bit more time to do, they got a better result, it's going to be much better than us trying to do something unnecessarily. And again, you will be surprised at the comments that I hear when I go visit a site or talk to it. It's eye-opening for them when I tell them this. It's like, hey, look, it's okay. Just do what is appropriate and what's right. Now, I will tell you, when you make a treatment plan, when there's a patient, when there's an insurance that says, oh, you have to tell us, you got to pre-authorize the phlebectomies, that's where it's really important that you look at that leg and you determine, yeah, you know what, I'm going to need 10 to 20 stabs here. And that's where we need to kind of be really, and ultimately at the same time, I would say if it winds up being that you wind up doing 8 and you didn't have to do 12, but you pre-authorized for the 10 to 12 or 10 to 20, I would still rather you just say, hey, you know what? We did 8 stabs. We documented that and we don't get paid for it. That's much better than trying to get to a certain number just purely to get there. Okay. And it's just not, the problem here, guys, is that we also are dealing with not just a compliance, but it also, your staff also see this, right? Your teams also see this, and just realize that we're always under the microscope, and somebody's always judging us. It's like, oh yeah, you know what, we're doing this because of this, and we never want to come across that way for our staff. Okay. Anyhow, I'll get off my soapbox for now.
All right, so Dr. Pravasti, then Dr. Aleskis.
Hey guys, what we do in Atlanta, I would say we're fairly, pro phlebectomy in general. And what we do for the dilemma of early thrombosis of large varicosities is we do believe in the staged approach because we believe a phlebectomy is not an add-on kind of procedure. It's its own significant procedure. And when done properly, we don't believe in just a sort of a stab and partial avulsion and partial interruption. We do try for a high percentage of removal of the vein. But so when we stage these procedures, we set it up so that the phlebectomy is within 3 days, ideally the next 24 to 48 hours after the ablation. So hopefully you intervene before significant superficial thrombophlebitis sets in. We have had great acceptance by the patients in this area, from coming in more than once in a week. That doesn't seem to be a problem for us. And that allows us to put the appropriate emphasis and effort into the phlebectomy and prevent thrombophlebitis. And if the patient shows up and it's the doctor's opinion that the phlebectomy is not needed, well, then the case is just canceled.
Thank you. Fernanda?
Having reviewed this subject, what is your thought with the availability of Varithena? What is your thought to the question, instead of asking concomitant versus stage with phlebectomy, the question being concomitant versus staged with Varithena? Any thoughts while you were reviewing the subject?
So one of the papers did include foam sclerotherapy in its data. And I think it was with the review of the registry data. So that that did include concomitant versus staged tributary treatments, including foam, and that paper basically suggested the same as the previous ones, which is that well, foam sclerotherapy is considered safe and it is considered effective when done concomitantly, and it does save some time. But again, I think part of it has to be at the physician's discretion, just because if you have extensive varicosities, then it wouldn't seem to make sense to do it concomitantly. At least for all those varicosities, we could only use so much foam. So typically, in my practice, when appropriate, I just, when doing an axial ablation, I typically only do distal sclero for the remaining portion of that axial vein, and save any other varicosities, for future dates. So, that's my approach, but I welcome anybody else to chime in on that.
So Marlon, you recently gave this talk at the Vision 2022 meeting. Do you have any, I know you've got some strong feelings about this. Do you have any comments about it?
I thought it was determined based upon what your patient's preferences are, and recognize that they just want to be pain-free and they've just got some real need, that they may get complete freedom of symptoms with that ablation. So it's a patient-by-patient decision.
Yeah, so it was a little garbled, but I think what Marlon said, that it's a shared decision-making paradigm. So, which I thought was a really interesting observation. If you look at the 2022 European Society for Vascular Surgery guidelines that just got published, when it comes to the issue of concomitant versus stage, they specifically use the term shared decision-making because like Abhi said, the main advantage to doing the concomitant is that you get earlier pain relief. So eventually they both come to the same thing, but it may take up to 6 months to a year for the stage group to have the same kind of outcomes as the patients who get it done simultaneously. So it really is kind of a shared decision-making model. You have to talk to the patients, find out what their goals are. If somebody really wants to go back to work quickly and that's an issue for them, that you may want to consider doing them concomitantly. The other thing that I think should be stated in this presentation is that there's only one paper that looks at the natural history of what happens to the tributary veins if you just do the ablation. And that's a paper by Dan Monahan that was published in 2005 in the Journal of Vascular Surgery. And what he found was that in 13% of his patients, the veins regressed completely where you couldn't see them. And he said that in another 30 to 36% of patients, they got smaller, they were still visible, but they weren't bothering the patients now. So in other words, they still may be visible, but they're not symptomatic, to the point where those patients said, you know what, doc, I don't want anything else done with them because I don't care what the appearance is, I don't have my symptoms anymore. So that was one paper that was done in a retrospective manner. So I think we really don't know what the natural history is of these tributary veins. Now, I will tell you from my own personal experience, I think Dan is right though about the 10 to 13%. I've seen that in small tributary veins, like 3 to 4 millimeters that come off a great saphenous just below the ablation site, that they tend to regress to the point where you don't see them. And to Ken's point about some of these thrombosing afterwards, if they're scheduled for a thrombectomy and they come in with a thrombosed vein, it's not a big deal just to do like a little evacuation of the hematoma. Plus, what I also do is I don't just evacuate the thrombus and the clot. I actually try to get the phlebitic vein out as well, because I think that leaving that phlebitic vein still causes some residual pain. But the question is, can it be avoided? So I'm not sure what the answer is. So I do think that the European guidelines have it right, that it is kind of a shared decision-making model. The other part that I always take into account is if you have somebody who's got, 15, 20 stabs, that takes a 20-minute procedure and it turns it into a 45-minute procedure, and then it becomes some scheduling issue. So it's not as simple as just looking at the data and seeing whether or not it's better for the patient. It's a whole factor of variables go into the decision-making, in my opinion. So does anybody else have any comments or questions? No? Ken?
No, I was just going to say thanks, Kos. It was a great talk, man. Appreciate it.
Thank you guys. Thank you very much.
All right, guys, everybody have a great weekend.
Thank you.
Take care.